Everyone, welcome to the third video in my dermatology resident series. So in this video we are going to discuss some onychology. This you can take a screenshot of what are the physiological changes in children and in old age that we see in the nails. Then this again you can take a screenshot of this thing. These are mainly for your exam purposes. I don't think they have too much of a practical relevance, but increased growth of nails is seen in certain conditions and decreased growth of nail is seen in certain conditions. Now clubbing is a condition. I'll describe it by this diagram. So the maximum bulge of the nail is point A, and at the proximal end of proximal most point you have taken the diameter as B. Now if A by B is greater than 1, then the patient is said to have clubbing. It is most commonly seen in thumb, index finger and middle finger. The shape of the nail is of watch glass type. Now clubbing is seen in all conditions that affect the heart and the lung. Hypertrophic pulmonary osteoarthropathy is a disease where you have clubbing of the nails along with hypertrophy of upper and lower extremity. Then there can be thoracic disorders, thoracic tumors, cardiovascular diseases, disorders of alimentary canal, endocrine disorders, hematological causes, hypervitaminosis A, malnutrition, kwashiorkor, addiction, syringomelia, LE, and it is also physiological. Koilonychia is when the nails are spoon-shaped. It is the opposite of clubbing. It is seen with iron deficiency and in systemic amyloidosis. It is also seen in Plummer-Vinson syndrome, where you have anemia, dysphagia, and glossitis. Pincer nails are when the transverse over curvature of the nails is more. That means your nail looks something like this. If this is my finger, the nail will look something like this. This is a pincer nail. So transverse over curvature, that increases along longitudinal curvature of the nail. It can be hereditary, it can be due to acquired due to ill-fitting shoes. It can be due to subungual exostosis. So basically what happens in subungual exostosis is when the nail has a bony outgrowth at the proximal part, then also nails can become pincer shaped. It can be seen in psoriasis, in onychomatricoma and other disorders. Dolichonychia, so usually nails are like this, right? The length is more than the width, but when it is excessively long, it is called dolichonychia. It is seen in Ehlers-Danlos, Marfan's onychoidism, hypopituitarism. You can take a screenshot of this. I think this is nothing, I mean there is no explanation to this. Brachionychia is when the width is more. So suppose this width becomes more, then it is called brachionychia. It is called racket thumb. It is an autosomal dominant disorder. Parrot beaking is seen in systemic sclerosis. Round finger pad. Now usually the finger pad is not very round. It has a triangular shape to it. But when it becomes round, then it is called Mitozani's sign and it is seen with systemic sclerosis. Polydactyly is more commonly seen in hand. It is seen with thumb and it is autosomal dominant. Now worn down shiny nails are seen in atopic dermatitis, chronic erythroderma, chronic scratches of rubber, pruritic disorder. When you have glossy shiny nails, it is called as worn down shiny nails and it is seen with the following conditions. Anonychia is when the nails do not develop. Onychoatrophy is when they develop but they become thinner, but they become smaller. Initially they are normal in size, but then they become smaller. Now longitudinal nails, longitudinal lines can be seen on the nail. Single longitudinal fissure is seen due to minor trauma, like this. It can be physiological. Onychorexis is superficial parallel lines, if you see. Then proximal nail fold can have myxoid cyst and warts. Median nail dystrophy looks like this. It is seen in nevus striatus and also in onychotelomania. There is something called as chevron nails. Chevron nails look like this. This is seen in children and it is physiological. You can also have transverse lines on the nails, which are seen in SJS, Lyell syndrome, cytotoxic drugs, and in these following disorders: Pitting, now we all know that psoriasis is irregular, random, irregular, deep and large pits, riddle. Alopecia areata, the name itself is symmetrical, the pitting is also symmetrical. Pitting is not just seen in these two, it is also seen in other things, so you can read this from here. 20 nail dystrophy, you can see where all it is seen, and you can take a screenshot of this. Now there is onychology or lamellar splitting. The nail looks like this. Plate of the nail splits horizontally. Repeated soaking of hand in water causes onychology. Proximal onychology is seen in psoriasis, LP and retinoid therapy. Distal is seen in chemical injury, old age, repeated wetting. Again, you can read it. You can pause the video and read it. I'll only be focusing on the parts where I need to explain something. Onycholysis is when the nail detaches from the nail bed. Now it can be proximal onycholysis or distal onycholysis. Now it is seen with nail psoriasis. Along with onycholysis, there is a very characteristic thing that happens in psoriasis. Can you see this whitish line and then there is this orangish reddish hue? This is very specific of psoriatic onycholysis. And this is an oil drop patch. If separation starts in center, oil drop sign is seen like this. Onychometasis is when the nail splits from proximal side. So if this is the nail, it will detach from here. This is onychometasis, causes a written on the screen. You can take a screenshot. Where there is one thing called Kawasaki. In Kawasaki disease, you see horizontal lines, orangish lines like this. Horizontal orange brown chromonychia is seen in Kawasaki disease. And in hand foot mouth disease, scarlet fever and Kawasaki disease, you can see onychometasis. Now subungual hyperkeratosis is when the normal thickness of nail is 0.5 mm. When it becomes more than that, it is subungual hyperkeratosis. You can note down the places where it is seen. Splinter hemorrhages can be seen in the proximal 1/3 or distal 1/3. Usually they are seen in distal 1/3 of the nail. They are seen with psoriasis, fungal infection, PRP, dermatitis, and this is how your splinter hemorrhages will look like. So most common cause is trauma, then psoriasis, then onychomycosis, and occasionally medications. And this is proximal, this is distal. If you want these notes, you can text me on Instagram. My Insta ID is passionate_dermatologist. I'd be happy to send these over to you. Then subungual hematoma is when there is bleeding below the nail. This is nail emergency when it is more than there's a certain fraction of nail, I think more than 50% nail, if it is involved, then it is a subungual hematoma is a medical emergency, because it can cause distal onycholysis by decreasing the blood flow in the distal nail. Subungual hematoma is painful, treatment is needed. And how do you treat it? You have to drain the hematoma with a scalpel blade or by drilling a hole through the nail blade. Hot paper clip cautery. So basically what you can do is, if this is the nail, you can either take a needle, warm it on a oven or a stove or something, warm it on a gas or something, and then make a burr hole, touch it to the nail, that will create a hole, and through that hole blood can come out. Or you can take a scalpel or a blade and make a small nick on the nail through which the blood can come out. Now you can elevate the nail, elevate the limb and decrease the pain. You can keep it elevated for about 30 minutes. The closest differential for subungual hematoma is a melanoma. But on removing the nail plate, no color change is seen on the nail plate. If you remove in hematoma, if you remove the nail plate, you will find that you can easily wash the hematoma as well. But in melanoma, it is not possible to do so. Then you can have ventral and dorsal pterygium on the nail plate. Pterygium is basically extension of proximal nail fold. This is the proximal nail fold which now the proximal nail fold extends over the nail plate and splits it into two. That is called a pterygium. Dorsal pterygium starts from dorsal side of the nail, and ventral pterygium starts from below the nail plate and it extends and divides the nail plate into two. This is an irreversible process and it divides the nail into two small remnants. Now other features seen in LP, it is usually seen in lichen planus of the nail. Other features that are seen in lichen planus of the nail are nail thinning, longitudinal ridging, fissuring plus atrophy, nail bed changes, onycholysis, nail discoloration is also seen. So topical and intralesional steroids are given for that. Paronychia can be acute or chronic. Now acute paronychia is seen with minor trauma. It needs urgent systemic antibiotics to prevent nail dystrophy. If it is not resolved in 2 days, then surgical debridement should be done. Incise at the size of maximum pain or at the site of maximum bulge, and then you drain the pus. Ipsilateral part of the nail you might need to remove the nail plate also with pointed scissors, and most commonly it is caused due to staph strap. If it is recurrent, then it can also be due to HSV. If acute paronychia is present, rule out ingrown toenail also. And in ingrown toenail, we know that we have to remove the offending, the involved parts of the nail plate, and you have to keep the dressing moist with saline or antiseptic soap until purulent discharge stops, and do full splinting and immobilization of the finger, hand and forearm. Bacterial culture, viral cultures you can send, Zangsmeer, PCR, viral culture you could do. Acute is usually on one finger, chronic is on more than one finger. Now in chronic paronychia, an important concept is that it is due to chronic inflammation and due to fungus. So if hands are commonly exposed to wet environment, or if there is repeated minor trauma, then there can be swelling and loss of cuticle. Acute exacerbation can be there due to secondary candidal or bacterial infections. Now due to cuticle damage, small abscess can form between proximal nail fold and nail plate. The abscess is drained spontaneously and hence the lesion subside without treatment. Now if there is recalcitrant or unresponsive to therapy, so I would like to explain this part. This is nail plate, this is proximal nail fold, distal nail fold and proximal. Here there is cuticle. If there is cuticle damage, then then this is proximal nail fold. It detaches from the nail plate and a pocket forms between the nail plate and proximal nail fold, and bacteria can seep inside and cause infections. So this is the pathomechanism. The fungus can seep inside, bacteria can seep inside and cause infection. In chronic paronychia, it is usually the fungus that causes the havoc. Now if it is recalcitrant and unresponsive to medical therapy, surgical removal of proximal and lateral nail folds together with proximal nail plate may be required. And topical steroids along with antifungals, you have to give topical steroids because the pathology is inflammatory. Now ragged cuticle is when the cuticle is uneven. Usually if this is your nail, there is a cuticle layer SC like this, but if it becomes ragged, then it is pathological. If the cuticle becomes irregular, it is called hyperkeratotic, irregular and ragged cuticle. If the cuticle becomes irregular, it is called ragged cuticle. It is seen with dermatomyositis, and it can also be seen in people who are nail biter, nail picker. Now this is periungual or subungual wart. It looks like this under the dermoscope. You can see pinpoint bleeding points. This helps to differentiate it from other diseases. It is caused due to HPV and it is benign, weakly infective. When it is localized to proximal nail fold, it produces proximal periungual hyperkeratosis, which resembles a hyperkeratotic cuticle. SCC can mimic a verruca. Suspicious lesions should be evaluated. Subungual warts can be painful. People often bite them, pick on them or tear them. Another DD is tuberculosis verrucosa cutis or systemic amyloidosis. Now you can use monochloroacetic acid dry, or you can use 40% salicylic acid, and then the wart can be removed mechanically also after a while. Now in case it is subungual, you might have to remove the nail plate. And cryo with CO2 laser or liquid nitrogen can also be used. Formalin with a toothpick can also be used to char the wart and take it off. Onychomatricoma is something which looks like this. Onychomatricoma, you have to avulse the nail and then you can see a matricial tumor with funnel shaped cavities on the proximal nail plate. On HPE, you will be able to see something like this, and on dermoscopy you see honeycombing appearance on the proximal nail fold like this. Honeycombing on the proximal aspect, you see honeycombing on free edge of the nail, sorry, not on the proximal aspect, on the free edge of the nail you will see honeycombing like this. And you can also see isolated splinter hemorrhages. So I think the splinter hemorrhages are also very nicely visible, so you can see splinter hemorrhages as well. Onychomatricoma presents like this. Now onychomatricoma is present on the fingernails more than the toenails. It is present as yellowish longitudinal bands, splinter hemorrhages, transverse over curvature, and on nail avulsion you would be able to see a villous tumor like this. This is onychomatricoma. Diagnostic, on HP you will see glove finger digitations. These are glove finger digitations. You can also diagnose it by MRI, and so nail plate thickening and all can be there. Then fibromas can happen. This is a picture of onychomatricoma again. Free edge has woodworm like features. This is woodworm like features, and you can see a longitudinal band with splinter hemorrhages on the dorsal surface. Now fibromas can be seen in keloid, dermatofibroma. Coinon's tumor is seen in tuberous sclerosis. Now this is what a fibrokeratoma looks like. Basically it is a benign tumor, asymptomatic nodule with hyperkeratotic tip and asymptomatic narrow base. It is asymptomatic only, it is seen in periungual area, and on dermoscopy multiple tipped fibrokeratoma can look like this. Otherwise also fibrokeratoma can look like this.